Europe, but not in Thailand yet or in region. So I will confine on these four agents: that Gasopivir, Elbasvir, Sulfodvir, Hepatosvir, Solvevog, and GP agent. Somebody said that it's quite difficult to remember, but I just give you a tip that everything end up with EVIR, it means protease inhibitor. It just depends on first generation or second generation. When it end up with Rsvir, it means it NH5A inhibitor. And Uvir, it means NH5B. The base agent had to be Uvir, the NH5B, in terms of drug resistance. So let's start from the first one, Gasopivir, Elbasvir. This is a fixed dose co-formulation in one tablet. So for easier, I will call just Sepatia. Okay, this is Sepatia. Sepatia containing Elbasvir is a NF5A inhibitor, and Gasopivir is a protease inhibitor. So let's look at the first study. Did look at the genotype 1 and 4 treatment naive, treated with Sepatia for only 12 weeks without ribavirin, without interferon. You can see overall SVR up to 95%, and you can see that genotype 1A slightly lower SVR than genotype 1B, which I will come back later. And this one can be used either in patients with or without cirrhosis at the baseline. So when you look in this one, look at the genotype 1B without cirrhosis. Sepatia just for 8 weeks, you can achieve SVR up to 97%. That's why it's easier now, single tablet without interferon, without ribavirin, and only for 8-week treatment you achieve almost 100% cure with the Sepatia. So regarding the side effect, you can see that the side effect quite minimal, and actually it's not significantly different from placebo. You can see only headache, nausea, and fatigue, and all these side effects are mild and transient. I had to draw your attention to one particular point. You can see, as I mentioned earlier, that Sepatia is more effective in genotype 1B than in 1A, because when you look at this one, genotype 1A in the patient without NH5A rash or resistant associated substitution, you can see that SVR is also very high, up to, I think it's running out of battery, it's up to 99%. But if the patient have rash NH5A at the baseline, you can see that SVR just drop almost half of them to only 58%. However, we can easily to manage this case by adding ribavirin and extend treatment duration to 16 weeks. Again, genotype 1A, even with NH5A rash, still achieve SVR up to 100%. So this also look at the Sepatia in treatment experience, that mainly patients fail from previous pegylated interferon ribavirin therapy. Overall, you can see that 12 weeks Sepatia achieved SVR 92%. And you can see slightly lower in some group of patients, which I will follow on. You can see what patient, the patient who relapsed from PEG interferon ribavirin therapy with 12 weeks Sepatia achieved FVR approach 100%, except those who previously non-responder. That means never have a more than 2-log decline during previous therapy, or have a virologic failure or breakthrough viremia. So this will be quite have high, slightly lower SVR than those who relapse from previous treatment. We can solve this problem easily by adding ribavirin in previously non-responder. You can see that SVR again up to 98%, even in the patient who previously virologic failure. So this is also important to look at the treatment experience in genotype 1. What you can see from this one, you can see those who had virologic failure, when you add ribavirin, even with cirrhosis, now you achieve high SVR up to above 90%. So this is important because, as you know, that sulfodvir is mainly secreted by the kidney. So sulfodvir is contraindicated among those who have chronic kidney disease, GFR less than 30 ml. And that's so really important, because that sulfodvir in the previous era is a backbone for all regimen. You send all the elegiment also containing sulfapyravir. So this is the first agent that have the regimen without sulfapyravir, and it not secreted by kidney, so it's safe in chronic kidney disease. So this study of Sepatier in genotype 1 patient with the chronic kidney disease state 4 or 5, GFR below 30 mil. You can see that 12 weeks without ribavirin, you can have SVR up to 94%. And even 1A, 1B, you can see, I said that 1B slightly better than 1A, but this study 1B contain a lot of subgenotype. That's why it contribute to slightly lower SVR from the original study. So, and in the patient with chronic kidney disease, either the patient on hemodialysis, not on hemodialysis, even they stage 4 or stage 5 chronic kidney disease, you can see SVR above 90% with Sepatier alone for 12 weeks. And look at the Sepatier in chronic kidney co-infection. This you can see that HCV, SCV co-infection, it also achieved SVR very high, overall together 95%, regardless of subgenotype or regardless of fibrosis status, with or without fibrosis, also achieving high SVR. Only one thing you have to remember, efavirenz is contraindicated to be administered with the Sepatier. So that's the major issue for hepatologists. If we want to use this agent, we have to ask infection doctor to modify their treatment regimen to get rid of the efavirenz. And this is the side effect, even in those who have co-infection, even they taking a lot of medication, you can see that side effects still mild and transiently. So now we go to Sepatier in genotype 3. In the era of DAA, genotype 3 is the more difficult to treat, always had a lot of lower sustained virological response. So this one, Sepatier itself not effective against genotype 3, but when they add the sulfapyravir, you can see only 8 weeks in genotype 3 without psilocin, SVR is 93%. And among those even with or without psilocin, the SVR quite high, except this one, but small number throughout patients with psilocin genotype 3, Sepatier with sulfapyravir for 12 weeks, achieve SVR 83%. However, we look at another study again. Look at Sepatier among genotype 3. Okay, this is a larger number of the patients. You can see that Sepatier without ribavirin, but put the sulfapyravir even in treatment naive or treatment experienced, genotype 3 psilocin, achieve FVR almost 100%. So put all together, this is how you can use the Sepatier, the new agent, in the clinical practice. In genotype 1B, treatment naive, or pegylated interferon experienced, you treat them 12 weeks, even in those with or without psilocin. However, only in treatment naive genotype 1B, you can consider 8-week treatment duration, achieve SVR around 95%. In genotype 1A, either treatment naive or treatment experienced, and had to be relapser, just give them Sepatier 12 weeks, in those with or without psilocin. In genotype 1, chronic kidney disease, you can treat them without ribavirin, without Teflon for 12 weeks, in those with or without psilocin, achieve SVR above 94%. In genotype 1-4, SAV co-infection, again, just 12 weeks Sepatier, and you have to avoid efavirenz. Among those genotype 1A with NS5A rash at the baseline or high viral load above 800,000 IU per mil, you can treat them with 16 weeks and adding ribavirin to Sepatier and achieve SVR above 94% in both patients with or without cirrhosis. And genotype 1 protease inhibitor treatment experience, again, just keep Sepatier for 12 weeks by adding ribavirin. The last one, genotype 3, with or without cirrhosis, you just add sulfapyravir into Sepatier for 12 weeks and achieve SVR above 95% again. Let's go to the second agent that also been recently approved in USA, Europe, but not in Southeast Asia yet. That's the sulfapyravir and Hepatology. So this contains sulfapyravir with the NS5B inhibitor, Hepatology with this NS5A inhibitor. So this study, ASTRO-1, looked at soft valve treatment for 12 weeks without ribavirin, without interferon. You can see that very highly effective, achieve FVR approaching 100% across all genotypes. This pan-genotypic effective. Genotype 1, A1B, 2, 3, 4, and 5, 6. So this really simple one because pan-genotypic effective and can avoid both interferon and ribavirin. Look at even those patients with cirrhosis and treatment failure with previous PEG interferon, you can see that either cirrhosis or no cirrhosis, treatment naive, treatment experienced, soft well just 12 weeks achieve 99% SVR. So easy, simple. Look at those who genotype 2, again you can see that genotype 2 soft well also achieve SVR up to almost 100%. Only one problem, genotype 3, as I mentioned earlier, that genotype 3, particularly treatment experienced and cirrhotic, had lower SVR. As you can see, soft well alone achieved quite good in genotype 3, treatment naive, treatment experienced with cirrhotic, SVR will slightly lower to 89%. In using DAA, I will say that anything less than 90% is suboptimal response. However, this our own study just published last year at ESO meeting. We look again soft well without ribavirin for 12 weeks for genotype 1, 2, 3, 4, 5, 6. Maybe you know that in Thailand, we are half of our hepatitis C patient infected with genotype 3 and about 10 to 20% infected with genotype 6. So this remains the question that we need to address. So we use soft well alone. You look at we done in Singapore, Malaysia, Thailand, Vietnam, or 18% were treatment experienced. As you can see that soft well alone pan-genotypic effective. Even in those with genotype 3 and with cirrhosis, we still have SVR up to above 90%. So I will say, again from that previous study with smaller number, we can use the soft well without ribavirin for 12 weeks, even genotype 3, cirrhotic and treatment experienced. And this confirmed by real world study from Germany. You can see much larger number of the patient. You can see soft well in genotype 3 without ribavirin. Even in cirrhotic patient, you also achieve SVR up to 94% in intention to treat analysis population and also 94% in per protocol analysis. So summary to all together for soft well, this can be used in genotype 1, 2, 3, 4, 5, 6 treatment naive, treatment experienced. So it's pan-genotypic, just simple, 12 weeks without ribavirin in those patients with or without cirrhosis. Except genotype 3, treatment naive, also 12 weeks. You just remember the one group, genotype 3, treatment experienced. For cirrhotic patient, you might consider adding on ribavirin for 12 weeks. So it's easy to remember. Soft well 12 weeks for all pan-genotypic or without cirrhosis, treatment naive, treatment experienced. Just may consider adding ribavirin in genotype 3 cirrhotic treatment experienced. So even it's simple to use, just bear in mind about drug interaction. I think you just go to the Google and search on hepato drug. You can check all drug interaction, but just bear in mind that soft and ready pathway and repertoire is not good to co-administer with PPI. And you see that PPI is a very common drug used, even not have the proper indication. So if the patient don't have proper need, take off PPI. But if they desperately need PPI, if you give soft well, you have to give low dose PPI, not greater than equivalent of omeprazole 20 mg a day, and you have to keep it 4 hours apart with meal. So better to stop PPI for 12 weeks. So we go to another agent is Capivir and Piratvisuth. This EVIR is NAT 3/4 protease inhibitor. Asvir is a NAT5A inhibitor, so called GP. Okay. This Endurance 1 to 4 study look at the GP among all genotype except genotype 3. Again, you can see that GP just only 8 weeks is highly effective and pan-genotypic up to 99%. Only 8-week therapy and not different than 12 weeks. And this confirm again with 8-week treatment duration to confirm that in patient with or without cirrhosis, you can see that GP just 1 tablet a day for 3 tablets because it co-formulated. You require 3 tablets, and then it just 3 tablets daily for 8 weeks. You achieve almost 100% all genotype except genotype 3. I'm going to show you later. So this again, look at even those with compensated cirrhosis. If no cirrhosis, 8 weeks, okay. If the patient have cirrhosis, just give GP for 12 weeks without ribavirin. It also achieve SVR almost 100% across all genotypes. And this look at genotype 3. You can see that genotype 3 again, in the patient without cirrhosis, 8 weeks also highly effective with SVR around 95%. But those with cirrhosis, just keep them for 12 weeks. So now simple, GP, 8 week, treatment naive, non-cirrhotic, all genotype. And 12 weeks for all genotype and with cirrhosis. And this among, except one group that more difficult to treat is the genotype 3 cirrhosis, and treatment experience is the group this one. Patient with cirrhosis and treatment experience require GP for 16 weeks without ribavirin. Just add more another 4-week treatment duration. In the patient who have RAS, who fail from previous DAA, you can see that with GP for 12 weeks, if the patient have only protease inhibitor RAS, GP 12 weeks also achieve really high SVR up to 100%, except the patient have NF5A RAS, it requires 12-week treatment duration or 16 weeks to achieve 94%. The one thing that we not recommend GP is those who contain both protease and NF5A inhibitor together in one patient, because you can see that SVR quite low. We recommend alternative regimen. So, and this also in chronic kidney disease is the second agent that can be used in patients with stage 4, stage 5 chronic kidney disease, GFR below 30 ml per minute, without requiring dose modification. As you can see, GP for 12 weeks achieve SVR up to 98% among patients genotype 1 to 6 with end-stage renal disease. And this is the recommendation for GP. You can see that genotype, pan-genotypic or genotype treatment naive without cirrhosis, only 8 weeks. With cirrhosis, 12 weeks. Genotype 3, treatment experience, 12 weeks without cirrhosis, 16 weeks with cirrhosis. Genotype 1-4, protease inhibitor treatment experience, also 12 weeks. If the patient have NF5A treatment experience, treat them for 16 weeks. But if they have both PI and NF5A, looking at another alternative regimen. So come to the last agent. This is sofosbuvir, hepatology, voxeloprevir. You can see this co-formulate one tablet contain NF5B, NF5A, and protease inhibitor. So that's why it's really effective. This is study of the SOLVE-WELL-VOX. It's a Polaris program. 1-4 in DA treatment experience, 2 and 3 in DA treatment naive. You can see really pan-genotypic. Okay, in treatment DA treatment naive, that means the patient maybe were treated with peglabarin but never received DAA. You can see that very effective pan-genotypic, except slightly lower SVR in genotype 1A. However, SVR still 92%. And you can see in DA treatment experience, some might have some RAS resistant at baseline. Again, you can see whatever RAS, you still have high SVR, which SOLVE-WELL-VOX for only 8 weeks. And except genotype 1A with NF5A, it's 80% that we recommend to give for 12 weeks, not 8 weeks. And look at the DA treatment plan. For simple, if you give 12 weeks for all patients without ribavirin, without interferon, you can see SVR up to almost 100%, pan-genotypic effective, regardless of RAS substitution. That's why yesterday my talk I said RAS currently is significantly impact in the minority of the patient with current available regimen, but with new therapy, RAS become not clinically significant, and that's why it currently recommendation if you treat the patient with SOLVE-WELL-VOX, do not to test RAS at all, because RAS testing means nothing. It's effective, whatever RAS, except only one the patient who remain left in the world. If they have a RAS cirrhosis, decompensated cirrhosis, as you know that protease inhibitor currently is not recommended in patient with decompensated cirrhosis. So this remain the patient behind. Those with RAS and decompensated cirrhosis, currently no available regimen. So that's why recommendation that if male score 18 above 18, send the patient for liver transplantation, and after liver transplant, they can be treated with soft wave VOC. So this recommendation for soft wave VOC, pan-genotypic DAA treatment experience, you can see give them only 8 weeks with or without cirrhosis. You can see achieve SVR approaching 100%. Genotype, pan-genotypic, again, except genotype 3, DAA treatment experience, give them 12 weeks. If the genotype 3 and DAA treatment experience did not peg in the front, the DAA treatment experience, 12 weeks indulged without cirrhosis and 12 weeks with libavirin indulged with NH5A treatment experience. So very easy for this regimen. So actually this talk should be for yesterday talk, the regimen simplification, but my yesterday talk, we don't have this agent yet, so this will come. I think the soft wave VOC and GP will be approved in Asia probably by the end of this year or the first quarter of 2019. So, and the last thing that I will just mention earlier, it remains this one, the patient cirrhosis with decompensated cirrhosis, GP and soft wave VOC with very high effective and pan-genotypic effective still contraindicated in patients with decompensated cirrhosis. The easy way to do right now, just put them on liver transplantation and then treat them after transplantation. After transplantation, it's also highly effective. But when we live in Thailand, sometimes it's quite difficult to put the patient on transplantation waiting list. My own experience, we do treat this patient if MEL score still below 18. Many of them quite respond well regarding the when you just closely monitoring and prompt management when the patient have complication or contraindication. And I thank for your attention.